So I'm at the ASH 2017 annual meeting, and today I wanted to discuss briefly the results of a subgroup analysis of a phase 3 clinical trial of CPX-351 versus 7+3 induction chemotherapy in newly diagnosed acute myeloid leukemia. Now you may recall this was a trial that enrolled patients aged 60 to 75 with high risk or secondary AML and randomized them between conventional 7+3 chemotherapy versus CPX-351. And the results of the trial demonstrated that there was an overall survival advantage that was attributable to CPX-351 in the entire population. We were interested also in exploring different subgroups to see if the data held up amongst other high-risk subgroups within this already high-risk AML population. And one population that came to mind was the patients that were considered to have, in the past would have been considered an MDS diagnosis or RAEB-t. These are patients that have between 20 and 30% blasts and had in the past been considered to have myelodysplastic syndrome as opposed to AML. Those patients have now been considered to have AML by the most recent criteria, and nonetheless still remain somewhat enigmatic in terms of treatment decisions. Most of the time we use azonucleoside therapies as frontline therapy for the MDS patients and even the lower blast percentage AML patients. So this was a foray into determining whether CPX-351 may also be effective in this subgroup of patients. And what we found in an analysis of about 75 patients with the RAEB-t designation, or 20 to 30% blast, was that the outcomes were very similar to the entire group of patients. In other words, we found that the patients with RAEB-t experienced a higher overall survival compared to 7+3 by about 6 months, despite having similar remission rates of around 45 to 50%. We also noticed that in the patients that went subsequently to allogeneic transplant, again in the RAEB-t subgroup, patients who had received CPX-351 had better outcomes than patients who were initially treated with 7+3. Again, these were patients who subsequently went to transplant, and their survival was landmarked from the time that they began the transplant. So indications that patients did better with CPX-351 compared to 7+3 in this high-risk subgroup of traditionally MDS-like patients. And I think lends some confidence to the fact that you can treat these patients effectively with CPX-351, similar to what you would expect with other subgroups within the high-risk AML population.